We had a patient with an ST elevation myocardial infarction who had almost no risk factors for coronary disease. She presented classic crescendo accelerating angina for the course of an hour or two, presented to our emergency department and had ST elevations in the anterior leads. When we took her to the cath lab, we saw a hazy cutoff in the apical portion of her LAD that looked like thrombus, but no obvious focal lesion. The closest we had was about a 60 or so percent stenosis, maybe 50%, depends on which angle you look at, right in the mid part of the LAD just after the takeoff of the primary diagonal branch. It wasn't a classic ruptured plaque. It wasn't particularly hazy around there, but it was the closest that we had to a culprit lesion that might have then caused an embolus down to the apical LAD. Well, our debate was whether to stent that location and just presume that that was the source of the embolic event to her apical LAD versus determine if it really was a ruptured plaque. And for that, we'd use intravascular ultrasound or some other imaging technologies. And in this case, we chose to use the TVC Imaging System to see whether there was evidence of significant lipid core in that area as well. I think the angiogram is very limited. I think the angiogram is always very limited unless something's pretty obvious. And in this case, we had evidence of an anterior MI, classic symptoms, and an embolic event distally that didn't seem to be explained by, or at least wasn't obvious, in the more proximal portions of the LAD. So in my mind, I had to prove that that actually was the site of ruptured plaque. The nice thing about intravascular ultrasound is that you can see plaque, you can see whether it's ruptured, you can see whether it's ulcerated. The downside is a lot of times you can't see any of that, and so you haven't necessarily ruled out a problem. You might see overall plaque burden. We chose to use the TVC imaging system largely because my thought was that there was probably going to be an area that had lipid core plaque. And if the lipid core plaque had ruptured and was there, and then I saw some imaging abnormalities on the IVUS that suggested a ruptured plaque, then I would say that was the culprit lesion and probably should be stented, or at the very least required intensification of medical therapy. I actually was pretty surprised to not see any lipid core plaque. The TVC imaging showed no ruptured plaque and actually only a modest amount of plaque burden, and no yellow whatsoever. There was none of the lipid core plaque that I expected to see. So the combination of two negative findings for a culprit lesion in ST elevation MI, I decided that this probably wasn't the culprit lesion and therefore a stent wasn't warranted. We treated her medically. Obviously we looked at the other arteries very closely, looked at the right coronary artery, found no other culprit lesion to explain this. She actually had almost no atherosclerosis anywhere else in her other arteries. So there was this one mild to moderate stenosis in the mid portion of the LAD that didn't seem to have caused an unstable coronary syndrome. So we treated her with aspirin and a statin at a relatively high dose, blood pressure control, and there was really no other procedural management that I thought was warranted based on the negative findings from IVUS and the negative findings from the TVC imaging system.